who cares about adherence? I care about medication safety, number one. Number two, concordance. Do you believe you should be taking this stuff, or does your son believe you should be taking this stuff, or your daughter? And then we'll measure adherence. CMS has it wrong because they're doing adherence first. So if you're adhering well to a lousy regimen, you end up with a broken hip. Okay. And in fact, we have another study that we're publishing, and it showed that people that used this system versus not used this system had a delta. It was 6 months, wash out 6 months, and then measure. It had a delta of $804 per member per year savings in Part A and B expenditure, mostly hospitalization. Mm-hmm. So it's the same stuff we've been talking about. So the medication safety, and they had less surgery. And we have this actuary group, out in the Midwest. It's a big actuary group. You know who it is. They're going through it. They said, well, how could you reduce surgeons? You're a pharmacist. How can you reduce surgery? Well, we said, look, if it's lower limb, breaking the hips, that's how we do it because they're not falling as much. Mm-hmm. Yeah. So and they said, wow, they couldn't believe it. Now they get it. Now they got it. But it's so if you get these actuaries involved, these big companies to double check you, and your peer review, you really get a couple of gold stars that way. And that's how we can market pharmacists. We say, look, we know if this pharmacist does this stuff, it's going to help you downstream.
Yeah, it's funny. When I worked at DaVita, we were in renal care, so we had my portion of population was at risk. And when we did the analysis at the end of the year, we only cared about total cost of care, right? That's what you guys are going at. And the first year we applied our group, the whole everybody got to audit, and no one believed that pharmacy added that much value. And we were like, the only thing you did different this year was you put pharmacy on, right? You do nothing different. The next year you add pharmacy and you drop, $10,000 per patient per year for this cohort is because we kept them out of the hospital. Mm-hmm.
Yep. And they're really interested in that even more now because right now, they are now more at risk. Mm-hmm. The government keeps making them more, the end-stage renal and chronic kidney disease, they're more at financial risk. So even now they're actually concerned about meds seriously.
Right. No, we were the start, like we did the SNAP programs. Yeah.
So in the eternal battle of independent pharmacy versus the big chains, are the big chains looking at MedWise and that kind of stuff? Are they doing anything like that? Do you see them ever doing anything like that?
Well, I don't know. I would hope sometime they do. I mean, they have pharmacists working there too, and they're pharmacists. I mean, I taught for 12 years too. Part-time, then 3 years full-time. I know so many pharmacy students I taught, and they don't want to come out. And we measured at the University of Sciences. We did a study back when I was there from like 84 to 94, and we did a study on our graduates, and we found that 3.1 years out. Those that went to work for a chain like CVS and stuff, 3.1 years, they're looking for something else. It's a hygienic factor. There's this study from years and years ago about hygienic factor, motivating factors, what moves people. And the hygienic is like compensation and stuff, but the motivating stuff is I feel good about my job. I feel like I'm making a difference. I have responsibility, all that kind of stuff. So the hygienic factor, when you're young and coming out of pharmacy school, you have loans to pay typically.
Yeah. Yeah. and Walgreens 2 years.
You're right. Guilty, right?
Yeah. Well, then so it's still the same. Wherever they're working, I still feel that most of the pharmacists want to use what they learned in school. But to answer your question specifically, no, we haven't really. We've worked a lot with small chains. They're not small, region like Thrifty and a couple of the HEB. A couple of those are working with us. But mostly it's the community pharmacists, the independents. So they're the ones that, in my mind, maybe I know I'm, kind of slanted on this, but in my mind, they're the most innovative. And you give them something, they'll innovate around it.
Yeah.
They'll find ways to dress up like you'd never even thought about before. And so that's really been my passion my whole life, is because that's what I grew up as, and I know these people, so that's why I'm so glad we're working together. Because we should be pharmacists are so important, and people are starting to realize it. But they're not realizing it enough yet. So I think that together we can really help them.
Yep, I would agree with that.
So I'm going to extrapolate this, fast forward like a little bit, 5-10 years. What percentage do you think in revenue does this clinical services you start to layer on start to make up for pharmacies?
Well, I really hope that it'll be like ours. We were 100 thing with PACE, for example. Now we're 50-50, that kind of stuff. And we have some pharmacists now that are really taking this seriously. They're doing concierge models.
Mm-hmm.
Yep.
They're charging PMPM.
Yep.
In the $20 to $30 range, and I think that kind of stuff is going to take off. But I also know that from what we're seeing, that some of these guys, Humana, some of these other guys, are also interested because they can see the results that it happens when pharmacies use a system like this. So then they're going to be paying for it too. But,
any progress there in private pay?
Yeah, there is, and it's not as much as it should be,
right?
But because and the reason is because you follow the dollars, right? I mean, they're incentivized on stars, and stars have to do with adherence mostly,
right?
And the more you have adherence, the better it's going to keep all of us in business because people are going to fall and break their hip all the time.
Mm-hmm. Yeah. So I wonder, is there a PQA play there with
measures
I
around
they're still working on trying to figure out how to measure what to measure at a pharmacy, right? PQA will tell you to your face, like, they were not intended to use PDC at a pharmacy level, right? It was
we had
at a health system or a plan level.
Yeah.
And so they know they've been measuring, or not PQA, right? PQA did it right. Everybody else applied it incorrectly.
Right. And they'll tell you to your face.
Right.
Like, these were health plan measures, not not a pharmacy measure.
So it's a matter of, they know there's something to measure at the pharmacy, but getting that information right now is really hard. Like, Independence, I think, could do a great job providing it.
But then why wouldn't? So what would a MedWise score be as a PQA measure? What if that was could that be a measure?
It could. I mean, you couldn't necessarily say, you'd almost have to do like a percentage of your patients under a certain score. But I mean, I don't know enough about the model to say, can you drive everybody to an 8? Right.
The commercial population, what we find in a commercial population, the score, there's about 8% of the people are 14 or higher, or above 14.
Okay.
In a Part D population, it's mid-teens above that, and we do have a couple populations, 25% over some of the. Right. Things with some renal of the care. CK, the end stage renal, that kind of stuff, they're really high.
Wow.
Yeah. So the interesting thing is, and talking about people caring about where the money's at, it might accidentally be an interesting and cool thing where you have some of the vertical integration between the health plan and the pharmacy. It sucks that they still own their own pharmacies, but like a Cigna and Express Scripts, they're going to start realizing that CVS isn't a good pharmacy. When they're on the hook for the medical dollars, that might be a cool place to, start to apply like a PMPM with, a MedWise score.